Hey guys, welcome to Season 2 of Capsule Production Podcast. We have a very special guest on today. His name is Dr. Allen, and he'll be talking to us about a really intense subject. So he'll be kind of giving his insight on death, dying, and critical care, and what role a pharmacist can play, and how they can actually help out in that type of setting. And before we start the episode, I just want to give a really big thanks and shout out to Randy and Greg for just kind of taking the responsibility and taking the reins on this project. Jeff and I have been away on rotations, and it's kind of hard to find time, but they've done a wonderful job, and they did a really great job on this interview. So appreciate it, guys. Without any further ado, we'll get started with the episode. I hope you guys enjoy.
All right, welcome everyone back to another episode of the Capsule Podcast here on the UF College of Pharmacy Orlando campus. Today's episode I'm very excited for personally. It's a little different than the other ones, and I'll get into the theme a little bit. Let me introduce myself. My name is Randy Badram, 3PD here on the Lake Nona campus.
And this here, Greg Celestin, here another 3PD at the University of Florida campus.
All right, and we're about to go on rotations, and we're lucky to have one of the newest celebrities on campus, if you will, Mr. Dr. Allen, and I'm going to let him introduce himself in a little bit. Today's topic is going to be about critical care pharmacy and death and dying. I think a topic that us as students, as pharmacy students, don't really get too much exposed to in the current pharmacy curriculum.
Definitely.
And I know that accreditation bodies are looking to add to this to give us the exposure. But without further ado, let me introduce you guys to Mr. Dr. Allen, if you don't mind.
Hey, so glad to be here, guys. Thanks for the invitation. As you mentioned, my background is critical care, and that's what I've been classically trained as, and seeing patients at their most vulnerable in terms of being in the ICU and being sick and being a critical care pharmacist. I think it's a big responsibility.
Absolutely.
When you see patients in their sickest state. So, trying to encourage more critical care pharmacists.
Absolutely.
Yeah.
All right. A little background for the folks out there.
Okay.
I know.
So
He's got a lot of letters after his name.
So he's being modest right now.
That just means you're a good test taker. Guys. You're a good test taker. No, or getting old, or some combination of the two. Born in Philadelphia, Pennsylvania. Born and raised.
Okay.
Fresh Prince.
Prince.
Fresh Prince. Actually, same neighborhood.
Oh, wow.
Look at that.
Will Smith. So small world, but West Philadelphia, born and raised. And then after graduating from high school, I just decided to go to pharmacy school. Was tired of snow and cold weather, so actually went down to Florida A&M in Tallahassee, Florida. And go Rattlers! Always, I think there can be love between Rattlers and Gators.
Oh, right? For sure.
Yeah, so I'm a Rattler, and then from there went on to do residency training, specializing in critical care at Tampa General Hospital. So know Florida pretty well, and have been in academia, but also spent some time in pharmacy administration as well, just working through a lot of diverse settings, but classically trained as a critical care pharmacist, and that's really where my passion lies, is caring for patients who are need us the most. Mm-hmm. They need pharmacy services the most. When you talk about they're oftentimes on multiple medications, their kinetics are altered, and there are a lot of things specific to critically ill patients that the use of medications that they need the assistance of a trained individual that specializes in drug therapy. So I'm gonna take a lot of pride in being a part of the team, and no place does interdisciplinary education and interdisciplinary care like an ICU. And when you guys go on rotations, you'll see that the critical care pharmacist is a valuable member of the team. And that comes from just bringing bringing something to the team and being a good team player. So.
Yeah.
Awesome.
Thanks.
If I'm a little out of it, I'm just in awe.
I know, right?
That said, that was real. That was well
legend
done.
right here.
That's cool. No, thank you, Dr.
The
Allen,
check
for
is in the
being
mail.
here.
The check is in the mail.
Thank you, just thank you for taking the time out to do this for us. I know I've had a few classes with you, heading the whether it be the ALS or the lab, and I've been really, really interested to hear what you have to say, and I think you project the information well to the students. So
Because I think we don't get enough of it in this career. I mean, we have a little taste, we have an elective, but it isn't, incorporated. So it's really something we should be getting our students prepared for, because they will experience something along the lines of death and dying or some form.
Yeah, and if not on rotations at some point in their practice or just life.
Right.
Right? So being able to have coping mechanisms to be able to function, right? Because you can, without proper coping mechanisms, it can be rough. So even to this day, there's still patients and stories that was privileged to be a part of in terms of the care of the patient where it didn't work out well, and those things still kind of stick with you a little bit, but hopefully they stick with you and make you a better clinician and a better provider of care.
Right, and because we usually don't think about the other side of the spectrum. We think about the patients and the family. Of course, they're the most important, but coping with it as a pharmacist, as a healthcare professional, it's something we definitely have to deal with as well.
Yeah, I mean, and I think when we talk about what are some of those things that a healthcare provider, not just a pharmacist, but a healthcare provider can do to cope and really move on is not the right word. What I'll say is be able to recognize that next patient in the bed deserves the same level of care, the same level of expertise as the one who was in the bed previously, right? So as a critical care pharmacist, death is something that we fight off. We're doing all that we can to fight it off, but unfortunately there are times where patients' illnesses are too great, and no single drug, no single therapy would change the outcome. And so I think the first thing in terms of coping is recognizing that that's the case.
Realistic,
right? Realistic expectations. So you said it well there. I think as much as we pride ourselves in terms of providing good care to patients and hopefully providing a good outcome, you have to realize that that's not in the cards for everybody. Yeah. So once you recognize that, I think it helps. It never gets to the point where you just move on past it. I think it gets to a point where you certainly put in all the effort and your team. It's not any single person. It's a team in the ICU. So the team puts forth the effort, but it is. There are cases where you recognize that, hey, this is probably not going to end well, and so you do everything you can to prepare the family and prepare the team around for that unfortunate event. So, one I would say is recognizing that it is an issue, or that not everybody's going to make it out the door, and that's something it took me a long time to get comfortable with, right? I can remember the first time I saw, I was on rotations, had a patient pass away, and so one of the things that our preceptor did, I was with two other students, so we were on rotations in the ICU, and the patient was in the process of dying, and so one of the things that our preceptor did was make sure that, and the team in general did, was make sure we gave the family privacy and made sure that we gave them the space that they needed to cope, because first and foremost, that's the responsibility, right? Is making sure that the patient and the family are taken care of and have privacy and have all the support that they need in that time. But as a student, there wasn't much that I could offer the family. So one of the things that our preceptor encouraged us was that, to not exit, but to make sure that we were that it was okay to walk away, and it was okay to recognize that our team had done everything that we could do for that patient. So making sure that we could feel comfortable, just taking a walk and just making sure just to clear our heads about the situation. So that was something that was impactful for me. Is luckily I had other students to kind of lean on as well, but that was a tough situation. But we also, one of the things, our preceptor taught us was it wasn't anything that we could do. Sometimes patients are too sick for us to save, but you gotta do everything you can. Also, you want to recognize that there's not shame, or there's no harm in being touched by the death of a patient. Sometimes as healthcare workers, tough persona, tough guy, but just recognizing that it's okay to be touched by the death of a patient or a loved one, a patient's loved one, and just being comfortable with that and embrace that. So I would think those things are things I picked up from preceptors along the way.
Yeah, it's kind of funny because as pharmacy students, we've come up with the idea of we're overachievers. We want the have impeccable records, and when it comes to patients, they're the same way. We want to see if we can help them in every way possible, and sometimes we can't. So it's tough. It's a tough pill to swallow for us when we have to realize that we can't help everybody, and sometimes it's going to end.
Yeah. So for example, sepsis.
Yeah.
Right. Patients who develop sepsis, depending on timing of antibiotics and things of that sort, the mortality rate can range from 10 to 50%, depending on how they present. So and that's best case scenario. That's doing everything that you can. There's going to be, unfortunately, a subset of patients that unfortunately don't make it. And as I said, one of the things you can do to cope is recognizing that, and to your point, Greg, is of us being overachievers, and we always want to get hundreds on tests, and I think there's a little bit of that, but in real life, that's not how life works. So just being comfortable with that.
Yep. All right, so
that's an excellent point. I just wanted to allude. I could sense your passion for critical care through your anecdotes there, and I just wanted to get a little bit into the background and wanted to see, why does critical care appeal to you, and what is the job of the critical care pharmacist when they attend to a patient with a poor prognosis?
So for me, I became introduced to critical care in pharmacy school on rotations, like many of you guys will encounter on rotations, and so I caught the bug pretty early. So for me, you guys will laugh about this. When I started rotations, my whole goal was to be an AmCare pharmacist. That was my whole goal. My whole goal was to go and work at a VA and rock their world with hypertension and hyperlipidemia, and critical care called. It was one of my first rotations was my critical care rotation. So what I enjoyed about it was the fast-paced nature of critical care. So recognizing that the decisions we make today can have a very real impact on what tomorrow looks like for the patient. Also instant feedback,
Yeah,
right?
instant
You get that
feedback.
instant feedback, right, of whether the patient's doing well or not. Additionally, I mean, they're complex patients, right? So they're patients who, again, as I mentioned, are at their most vulnerable. So for me, that's a big responsibility, right? A patient who's at their most vulnerable and they need us, being able to be privileged enough to care for that patient and offer expertise as it relates to drug therapy is something that intrigued me. There was a genuine need for a critical care pharmacist, like, in terms of being in the ICU. Critical care pharmacists play a huge role in everything from optimizing drug therapy, preventing adverse drug events. We talk about parenteral and enteral nutrition being involved along those lines, assisting patients with who are in either liver dysfunction or have acute kidney injury. I mean, there's such a role for pharmacists in critical care. So I felt as though I wasn't limited when I was in the ICU. There were the team always was asking us questions and how can we do this better, and so it just was really really the perfect environment for me. In terms of how do I handle patients with a poor prognosis, I would say, one of the things that you have to recognize as a not just critical care pharmacist, but critical care practitioner is that there are certain things that we can do to try to improve an outcome. Right? So, for instance, sepsis, as I talked about earlier, we know that fluids and antibiotics are game changers when you start talking about risk or survival or not. So making sure that we do those things, right? Like in terms of, are we doing everything that we can?
Yeah.
Those patients, probably watch a little bit closer, comparatively speaking. And as an ICU pharmacist, who the sick ones are. The ones that are really in need. Not all ICU patients are created the same. Right, so if I see somebody who's on 3 vasopressors, is on multiple antibiotics, and is still not doing well, and they're now in a acute kidney injury or acute kidney failure, that's somebody I'm probably going to spend a little bit more time and focus in terms of reviewing their meds and seeing is there anything that we're missing. But at the end of the day, if you have put your best foot forward and done all that you can do, there were times, when that happens where, patient doesn't make it, you're like, is there more that I could have done?
Yeah.
And, I think if you put your best foot forward in terms of, optimizing drug therapy and doing, working with the team to help with that, just sleep well at night. Recognizing that you did everything that you could. So
That's a good point.
That's a good point. Well, everybody isn't Dr. Allen, and we have a lot of students that kind of shy away from this. It's a common thing on rotations. They're afraid to attend the code. They dislike the critical care environment as a whole because of like the grim situations they might see. So, what do you tell these students that are afraid? How do you push themselves? And would you recommend students to experience something like this at least once?
I think. So I'm already biased because I'm a critical care guy, right? So, but what I'll say is that the critical care environment, it can be a tough environment. I don't want to minimize that, but I think it can give you a picture in terms of even if you don't go into critical care as your ultimate field within this profession of pharmacy, I think it can give you a good perspective on life, and it gives you a good perspective in terms of recognizing that, okay, I had a bad day today, but there's others that have had worse days.
Yeah.
And so from that perspective, I think it is valuable for students and for healthcare providers to remember that. In terms of the nitty gritty of doing the work of being a critical care practitioner, and how can a student, let's say, who's not as interested in critical care, who happens to draw the short straw and get it as one of their rotations, I think you make the best of it in terms of recognizing that there are things to be gained from every rotation, right? So, as a preceptor, one thing I used to always do was at the beginning of the rotation, ask the student, what is your career goal? Like, not necessarily, specifics, but do you want to go into retail? Do you want to go into independent pharmacy? Do you want to go into academia if you're crazy? So that was something I did to try to help tailor the rotation for the student. So for instance, I have a student who, in my previous experience, I was privileged to work in a trauma ICU. So I would encourage the students, even those who didn't want to be there, to talk to me about, okay, this patient's on these medications. Talk to me about how you would counsel them going home. So I think a lot of it can be how you go in with a mindset of, glass half full versus glass half empty, right? And just trying to identify opportunities in terms of how this might impact me in another career, and always taking every opportunity. You'll never, for a lot of students, that may be the only time they're ever in an ICU in terms of providing care. So I think it can be helpful in terms of, again, the perspective standpoint, but also you learn a lot of things in the ICU that can be applicable to other places. I'm selfish that if you can take care of a critically ill patient, I think you have the ability to take care of multiple types of patients. And I won't say all patients. There are certainly types of patients that I am not able to take care of. So, and will say so without any reservation that there's patients who I'm not able to take care of. But I think critical care makes you well-rounded. You can you see things from an infectious diseases standpoint. You see things from a cardiology standpoint. You see things from an internal medicine standpoint. You see a little bit of diabetes, hypertension, stroke. So you can see a lot of different disease states. So that's something I think that would benefit pharmacy students as well, because they may see other disease states than, or you can see a wide variety of disease states.
Yeah, and I think it has a lot to do with the margin for error. It's like the difference in a critical care setting. If you make a mistake, that can be the difference between life and death versus in another setting, you might piss somebody really off, but you won't kill anybody.
Exactly.
So I think that's what kind of strays people away, because people are afraid to.
But for me as a preceptor, right? Like, my job as a critical care preceptor is not to put all the weight on the student's shoulders, right? Like, and I think in any setting, it's not the preceptor's job to put the weight of.
We appreciate it.
There you go. I tell students, make mistakes on my license. Don't make mistakes on your license. And so when I say that, certainly I value my license as well. Sure. So I'm not going to let you, to the best of my ability, hurt a patient.
Right.
Right. So that's the time really to venture out there a little bit and hypothesize about certain things and just recognize that it's okay to be wrong every once in a while from a student perspective. One thing I think rotations is really helpful for is to recognize that it's okay to have a difference of opinion. There's more than one way to do things, right? So I encourage students when we're on rotations having a discussion about a patient. If we don't know an answer, and I totally appreciate if you don't know the answer, saying you don't know the answer. I appreciate that 100%. But for me, I don't let students off the hook.
Right.
Right. I want you to think about it. What is your thought process about best guess,
Right.
and then we can work our way through it. But I'll say that that is something that can be helpful in terms of being in ICU. Is it helps also stimulate critical thinking as well, because you have to think on the fly.
Yep.
That's good. Perspective. We talked a lot about perspective, and especially in the ICU. The biggest question in the ICU, from the perspective standpoint, is both families and clinicians, is whether this patient will live or die. In your experience, anything clinically that you found that will typically suggest a patient will survive or not? Or are there any certain vitals, biomarkers, medications, length of stay, surrogate outcomes, et cetera, et cetera?
That's a light.
Yeah. So I tell you, if I had that, I would have a money.
Yeah, you have a lot.
I would have a lot of money. Right? But what I'll say is there are certain prognostic indicators that say whether a patient is likely to have a poor outcome or not, and so we try to alter those things. We try our best to not do those things that will lead to worse outcomes, like I talked about with sepsis, and making sure we give antibiotics and fluids appropriately, and then making sure that we try to do everything we can to prevent a patient from going into acute kidney injury and things of that sort. But are there certain things that I can look up and say, oh, you're not going to do well. Oh, you're going to do well. There are some of those, but none that will say whether you're going to live or die. I think those markers can be used to dictate or help us to identify prognosis with respect to certain outcomes. But for instance, in patients with sepsis, it's known that an elevated lactate level, serum lactate level, is associated with worse clinical outcomes. So I can know that. I can recognize that that patient is probably at worst or at higher risk for an adverse outcome, and we do our darndest to make sure that we give fluids, give antibiotics, right? So what I'll say is you use those markers, you use those vital signs, and somebody with a low blood pressure as a way to identify who's in the greatest need.
Yeah.
But I don't think you use them to say, will this patient live or will this patient die? So I hope that helps a little bit, at least to clarify.
That makes sense.
No, indeed. I had a quick follow-up on that. Talking to families about, let's say, a prognosis that's not looking so good. What are maybe some tips and things like that? Especially us threes going on rotations.
That's tough. That is a tough question.
That's why we're here, folks. On the Capsule Podcast, is to ask those tough questions.
Yeah, and see Dr. Allen sweat. No,
You're sweating right now, right?
So what I'll say is that when we're talking to families, recognizing that there's no words, there's nothing that you can say that will bring that loved one back. So recognizing that. But from my experiences, I think recognizing when to give space to a family member versus just being present. Because sometimes just being present is enough.
Yeah.
All right, so those are two dichotomous things: being present and knowing when to exit stage left. But I think you judge that based on your comfort level with the family. Oftentimes, and when we talk about the ICU, it's a team, right?
Yes.
And the person or the folks that are closest to the family are the nurses. So that's a shout out to critical care nurses. Those folks are some of the most dedicated, smart, most passionate caring people that I've ever been around, and they oftentimes are the ones that are there with the families, and they are there because they spend 12 hours a day at the bedside, right? So they get to know the families really well. You know, as a pharmacist, I don't ever feel like I have to be a superhero to go talk to the families about it, but I think because our nursing colleagues do a heck of a job at that.
Absolutely.
And so I think recognizing when to give space versus when to perhaps just be present and give a hug or anything along those lines. I think I can't give you do this at this time, but
No
I
guidelines
think
for this.
but there's no guidelines for this, my friend. But just recognizing that being part of the ICU team, that you don't have to take on that responsibility as a whole, and it's tough. That is definitely a tough situation. You guys made me sweat on that.
That's actually funny we bring that up.
Yeah.
I actually have a story from my hippie. We were this regular med directs. We were going from patient room to patient room, and we got to this one room where prognosis wasn't looking too good. The son was there with the mother, and we're just trying to get the medications, and asking him questions. And he started breaking down, because he's preparing himself for what's about to happen. And while I'm taking it, I said those dangerous words. I said, I understand. You know? It was, and I got. He chewed me out. He's like, "Do you understand? Do you really understand what I'm going through?" And I mean, at that moment, I was like, I can't. And it's weird because it's a natural human reaction.
Correct.
To say I understand if my niece gets hurt, I say, and oh look, I have a cut here too. It's not gonna hurt that much. And so that's like a natural human reaction, and to try to suppress that and give them their space or just try to react as a healthcare professional, try to separate the human from the healthcare professional is a tough thing.
And so what I'll say is that, you bring up an excellent point, but what I'll say is I don't think you have to separate the human from the healthcare worker, right? Like you can still be a healthcare worker and be compassionate and still want the best for patients and still be caring of patients, right? Like you can oftentimes, sometimes see in the hospital setting where you guys may have seen it during your hippie rotations, and you may see it during your appies, where sometimes family members or healthcare workers may appear unfazed or may appear to be desensitized, right? And so I think that comes from having done it for years and years and years, right? Where you can kind of compartmentalize things. And so, that's something that certainly comes with time, where you're able to recognize that, you can't live or die with every patient, right? You will burn out very quickly if you are, the highs get you excited. For instance, we get a patient out of the ICU and home. Those are wonderful times in an ICU, because particularly those that have been there for an extended duration of therapy or extended duration. We all want that. That's great, and we're excited about it. But at the end of the day, you kind of have to learn how to not get too high and not get too low.
That's an excellent point.
Yeah, and just as much as, and I hit it on it a little bit earlier, as much as we ache and we hurt and we are upset about the loss of a patient, and it's never a good feeling. That next person who rolls into that bed is just as sick, deserves the same level of expertise, because that's somebody's mom, dad, brother, cousin, father, mother, cousin, aunt. That's somebody's loved one. Absolutely. All right, so I owe it to that patient and that family to provide the best level of care. So what I'll say, that I think that's how healthcare workers kind of move past it. So I wouldn't say they're unfazed or they're desensitized to it, but I think it's just you after doing this for a while, you realize that for your own sake, you have to be able to
Maybe
be in the present,
Yeah.
be in the present, right?
Okay.
And recognize that not that you owe it to the next patients that come after to provide good care.
Perspective.
That's good.
That's awesome.
So some pharmacists, they take a supporting role in coach situations. Others act like as leaders. What do you think the pharmacist's role should be in this type of setting? Or at least, what do you think they should be doing at a bare minimum?
So what I'll say, first off, it's going to be dependent to the institution. Right? So if at your institution where you are, pharmacists don't participate in codes, certainly I would try to gain that expertise so that pharmacists could participate, but again, that'll vary from institution to institution. What I'll say is, I think all of the above, right? Like, I don't think there's so for instance, I've participated in numerous code situations, and I've done a few different things. It's never where I only did one role, right? Ideally, you're the medication expert, so you would be preparing the medications, epinephrine or atropine, and or any other drug that you would use during the code situation. You'd be expected to prepare that if it's in the cart, and if it's not in the cart, facilitate it getting to the patient. But there have been times where I've had to step in and give chest compressions, and where you're looking at a EKG, and if there's a young medical resident, for instance, who's running the code, who's fresh out of med school, sometimes that can be challenging for them, right? So as one could imagine, right? So being able to say, hey, you probably want to use epinephrine here. You probably like being able to provide a little bit of expertise there can be helpful. But what I'll say is there's, it certainly depends on your comfort level and depends on your skill in that area. But I feel like whatever is needed, right? Like in a code situation, it's all hands on deck. So if they needed me to go get some tubing to start a infusion, I went and got it. If it was something that wasn't right in my wheelhouse as a pharmacist, you adapt and you figure out how to do it. So the long and short of it, I think you're a pharmacist. You know the medications. That's your job. But so if there's one job, that's what you should be doing at minimum. Be the medication expert as it relates to drugs that are used in code situations. But being asked to jump in and give chest compressions, being asked to go do something, whether get a bag of saline, get flushes, whatever. I think you do it because at the end of the day, it's not about titles or who's doing what. It's about like the patient that's in the bed who's in asystole, and we're doing our best as a team to try to change that outcome. So
that's good.
Excellent point.
And do you ever? I guess this is a follow up.
Yeah.
Do you ever see any situations like that where titles do get in the way of a coach situation?
Yeah, I mean, I think a lot of it too, is so. In ACLS, a lot of it is about communication, right? And making sure that what is asked for gets done. And when something is asked that is not appropriate, then, somebody be willing to speak up about it. So, for example, let's say certain medications are to be done. ACLS recommends every 3 to 5 minutes for certain medications. If it's been 3 minutes it's been 5 minutes and no other med has been ordered, it's okay for somebody to speak up and say, hey, it's been 5 minutes. Do we want to give another dose of epi? Do we want to give another dose? So I think as the pharmacist, and so everybody on the team has a role. There's a timekeeper. There's someone who gets the medication. There's a nurse. There's a team lead, obviously. But I think the times where titles get in the way is when folks are afraid to step up and challenge when things like that need to be said. You certainly say it in a respectful way. You certainly say it in a way that is not aggressive or overbearing, but you say it nonetheless.
Yeah, there's life at stake.
Yeah, right. Like at the end of the day, as a healthcare worker, you would hope. Can't say that is true everywhere. It happens in every situation, but everybody's on the same team trying to achieve the same goal. So whether I say, hey, it's been 5 minutes, or it's a nurse, or it's a RT, or whoever, as long as it's said and is addressed by the provider or whoever, I don't care who gets the credit as long as the outcome is
Exactly.
great. So.
Now, I'm going to ask you to, because you've had a lot of students that you precepted before.
Yeah.
Now, I'm fresh going on to my rotations.
Yeah. You guys are baby pharmacists.
Baby. And, unfortunately, patient that we were working with has passed on.
Mm-hmm.
What do you remember telling to maybe a previous student to help them cope? What would you tell, let's say, me?
No, I think from a preceptor to student standpoint, the preceptor has to be comfortable with a few different things. Preceptor has to recognize that this is probably, and it may not be true in all cases, but it's probably the first time a student has seen this happen, see a patient die. So as a preceptor, I need to recognize that in a student and make sure that they're okay and it's okay to be upset about it, right? Some of those principles we talked about. It's okay to recognize the hurt that comes from a patient dying, but also once you recognize that, saying it's okay for the student to walk away for a minute and just clear their head and to gather themselves. I've had students where this was their first time seeing a patient die, and were just devastated, by that scenario, and that's where you take them into a private area and try to it's okay. You try to be there supportive for the student, but recognize that it's okay, and that there's not, in that scenario, there wasn't anything that we could have done,
Exactly.
no medication that we could have done, no recommendation we could have made that would have changed that outcome. All right. So recognizing that and putting the student at ease there. Also, I think once you highlight and recognize that, not everybody's going to make it, unfortunately, as sucky as that is. Unfortunately, that's not in the cards for everybody. So once you recognizing that there's no shame in losing patients, there's no you aren't less of a pharmacist or pharmacy student if that outcome happens. Recognizing that, and then I think the third thing is just making sure that you have an outlet to decompress as it relates to this, right? So I tell students that are not on rotations that you need to set aside some time for yourself and do other things, right? You can't be all book work, all schoolwork. and not have an outlet to decompress. So I would encourage a student, if that was the case, that perhaps that be something that they look into if they don't already have something. And it doesn't have to be anything elaborate, right? I mean, a lot of times think, well, it needs to be something where I go out somewhere, or I mean, maybe it's just reading a book. Maybe it's just sitting outside watching the clouds go by. I don't know,
maybe.
But basketball, whatever, right? It doesn't have to be anything fancy, but I think you need to have an outlet to be able to deal with that, and hopefully, all those things combined will be helpful. One thing I think that is important is that, and that students can't lose sight of, is that the exit part of it. Because when I and it's been well described in the literature, that patients, that interaction, so if a loved one dies, healthcare worker, that interaction with the patient's family is probably harder on the healthcare worker, because there's a sense that you let them down. There's a sense that we have failed this patient's loved ones. But in reality, if you've done everything that you can, I think that's kind of how you have to think about it. So it's recommended that to give a little bit of space if to families if you start to experience some of that. Yeah. So I mean, there have been times we had patients who died, and we remember one vividly: trauma ICU, 13-year-old patient, ATV accident, in the ICU for months, and then just all of a sudden gone. And that's probably the roughest that I can remember, and I don't think I'll have another one that affected me that much. But that was the one we were all crying in the ICU on that one. That was tough, but you recognize, and the families are so appreciative. The family, a lot of times, we talk about certain experiences, but my experience has been, if we're doing everything we can and we're show empathy to that family, that they are appreciative, and they're appreciative of what we do, but just recognizing that sometimes it might be easier to step away, as opposed to engaging, because you don't know how that interaction will go. So
and you kind of alluded to it before, the kind of macho man approach that healthcare professionals get. Like, we're supposed to internalize all of this and not really vocalize or process what we're going through. So I think it's a really really good point that we need to kind of process it with our preceptors, with our friends, with our family, because we're affected by it just as much as the family. So.
Yeah, I mean, and the challenge is that you don't want to carry that burden. All right, so the challenge, you obviously want to provide good care to the next patient, right? That's the goal, right? But you also, it's easier said than done in terms of not carrying that burden. I mean, this is like almost 10 years ago, and I can still say I can tell you what happened, right? So there's certain stories that stick with you, but at the end of the day, not, again, recognizing that that outcome was not that wasn't caused by not doing anything, and it wasn't caused by doing something incorrectly, right? That was just the nature of the patient's injuries. But I can say from in that experience that we did everything we could. It sucked, but and I was okay with being vulnerable about it, because that's not. I don't think that's anything to be afraid of or to be nervous about, right? Where you can show your emotions. You're with the team. This is the team who's doing this. So, you know,
Everybody's got a lot invested.
Yeah,
You know, I can
yeah.
only imagine. You know,
yeah.
the outcomes. You know, definitely the sad outcomes. How that can affect and have maybe some residual effects.
Agree. I mean, but what I'll say is also that there are a lot of good outcomes
Yeah.
that come as well, right? So you know, in terms of recognizing that, you know, not everybody's going to make it, but there are a heck of a lot that do make it. Good, and recognizing that you know, it's not all death and despair. That I say, I don't want the listeners to leave with that. There are times when it happens, but you know, and you have to learn how to deal with it. But I think we do. Most will get out before we can do harm to them. Most get discharged before we hurt patients. No, I kid, of course.
Yeah.
I kid, of course.
Does it get easier, you know, over time with experience?
I think for depending on who you speak to, I'll say yes, but I think you know, for some folks, you know, I tend to be a glass half full type of person anyway, right? So I don't try to let defeats linger too long. You know, you try to move on to the next thing. But with that being said, I think you know, healthcare workers, we do tend to try to compartmentalize, and in some aspects that's healthy to get to say, I'm going to do my job here, and I'm going to take care of this patient that's in front of me and be present, because this patient needs it. But I think if you internalize it and you don't deal with it and decompress, that's when you'll have the problem. So I think being able to have that outlet, you know, you compartmentalize because you're taking care of another patient, but you have to know how to let it go and try to find an outlet to take your mind off of some of that stuff. So it's easier said than done, and to the point of, does it get easier? I think it does, but it never completely goes away. Right. It never goes away that patient didn't do well, and it just. I hate to say it is what it is, and that's not what I want the readers or the listeners to get from it. But at the end of the day, you can drive yourself crazy if you take home every poor outcome that happens, and you recognize that that's somebody's loved one and that's somebody's family member, and you be there for that. But I think to recognizing that it's not always in the cards can help you to move past and move towards taking care of the next patient. So
That's a good point.
That's a good point. So
death and dying is inevitable, but I think one of the points that I definitely take away is not letting the highs get too high, and not letting the lows get too low, and not really harping on those two extremes, and just trying to get that middle ground.
Yeah, it's tough. It is tough. It is tough, and it takes time. But you know, when you see something enough times, you're like, oh, that's old hat. So you know, that's just like human nature, right? Anything, you know, first time you see something, it's dramatic to you, good or bad, and hopefully over time, you're still not on the roller coaster ride with your highs and lows. Hopefully you've evened out a little bit.
So we're gonna wrap up here a little bit.
Oh man, it's been fun.
It's been fun. But I really want to know, how does someone become one of the legend, the Dr. Allen? Say like someone wants to become or get into critical care. What are some tips you have for students out there listening to this?
Well, so what I'll say, what I'll say is, so thank you for saying that. I appreciate you. I'm just a pharmacist, teacher, researcher, trying to save patients one day at a time. But what I'll say is just across the career, right? So like not just critical care, and I know your question was specific to critical care, but what I'll say in general, right, is like find good mentorship, find somebody that you can learn from. You don't have to, when we talk about, you can learn from other people's experiences as well, right? Oh, yeah. I don't have to, I can see Randy touch the hot stove. I don't need to touch the hot stove to recognize that it's hot, right? So I think there is some of that. Finding good mentorship, I think, is key. I was privileged and blessed to have several mentors. My residency director during my critical care residency, somebody who I met as a student and continued to this day to be a lifelong friend, and somebody who gives it to me straight. And so mentorship would be the first thing, I think. And then not being afraid to fail. Mm-hmm. Right. A lot of times, students can, and when you're young in your career, you don't want to step out a little bit, and I think you grow more from your failures. So don't let every failure defeat you, right? Right. So, but what I think, just recognizing that failure happens in life, and it's not it's how you respond to that failure that'll make you a stronger person or not. So, I know you asked about critical care, but
I'll take that.
Yeah. So, but I think for just in general as growing into being a pharmacist and doing great things, I think that those are a couple of things, and pay it forward. Right, there's going to be somebody behind you who also is coming up. If you're doing great things, which I'm sure all of you guys will. That'll come up, so don't be afraid to pay it forward as well.
Absolutely. Thank you.
All right, well, unfortunately, it is that time. No, Dr. Allen, thank you. As always, very informative session we've had here. Lots of new information to process. I think the experience and the stories and just, again, like that mentorship that you have here on campus, I think is an asset to the building, the college, and to us, your patients, etc. Thank you again for the time. Maybe we look forward to doing another episode with you.
There you go.
While we're here, we're going to pay it forward, right? So right. Jeff and Brandon have the check in the mail. Thank you so much for joining us.
So
and hope
much.
The audience there, I'm sure you learned a lot and can use this information in your practice and as prospective students or in life in general. So thank you again for joining us, you guys.
Thank you, Dr. Allen.
Thank you, Dr. Allen. Thank you, Greg. I'm Randy. Thank you for listening to another edition of the Capsule Podcast, you guys. Have a good rest of your day.
Well, that's it for another episode of the Capsule Production Podcast. That was a really heavy episode, but a really important one, I think. So hopefully you guys learned something from that. I would like to thank Randy and Greg and Dr. Allen one more time for doing a fantastic job. Again, I think that was a really great episode. And as always, if any listeners have any questions, comments, or if you guys want to hear about some kind of specific subjects, just let us know. You can find us on Facebook at Capsule Production Podcast, or email us at capsuleproduction1@gmail.com. And finally, thank you to Sephiros for providing the music. This song is called Celestial, and you can find it at freestockmusic.com.